See, today's topic is Bologna criteria for poor ovarian response and its limitation. Okay. So it is taken from the ASHRAE consensus 2011. See, Bologna criteria was introduced in 2011 by ASHRAE to address the lack of standardization definition for poor ovarian responders in ART. Okay. The purpose was to standardize the definition of POR for research and clinical use. What was the definition of Bologna? A patient is a poor responder if they met at least two of the 3 points. It gave 3 points. From those 3 points, at least 2 points it should meet to say it is in Bologna criteria poor ovarian responder. So what were the 3 points? First point was advanced maternal age, that is greater than 40 equals to 40 year, or any other risk factor. Okay. Second was a history of less than equals to 3 oocyte retrieved in normal stimulation cycle. Less than equals to 3 oocyte retrieve in normal or conventional stimulation cycle. Third was AFC. Third was about abnormal ovarian reserve markers like AFC and AMH. AFC 5 to 7, less than 5 to 7, and AMH less than 0.5 to 1.1 nanogram per ml. AFC, interfollicle count, is from both ovaries. Okay, from a single ovary, we say it as FNPO, follicular number per ovary. Interfollicular count means both the ovary. We have taken follicles from both the ovaries. So according to Bologna criteria, if it's less than 5 or 7, 5 to 7, then it is one of the 3 points in Bologna criteria. And if AMH is less than 0.5 or less than 1.1 nanogram per ml, then also it may be it may be the third point of being a poor ovarian responder in Bologna criteria. So, a patient is said poor responder if at least 2 of these 3 points are met. Okay. Now, alternatively, it said if a woman has experienced two instances where her ovary did not respond adequately. Did not respond adequately means 1 instant and 2 instant. Means less than equals to 3 oocytes were retrieved to a maximum ovarian stimulation. She can be classified as poor ovarian responder even if she does not meet the typical criteria of being advanced age. If she's not even meeting advanced age criteria, or her ORT such as AFC and AMH are normal. Okay, so if this woman experienced 2 instances, 1 instant, 2 instant, where her ovary did not respond adequately with maximum ovarian stimulation. Now, see, this allow for the flexibility. This alternative definitions allow for the flexibility. Okay, in diagnosing POR, poor ovarian response, agreeing that some women may have unexplained cause or some unique factor which may be affecting the ovarian function that may not be captured by age or abnormal ORT or ORT result. Okay, example is, see, if a woman with POR receive 450 international unit per day of FSH, means it's a maximum stimulation. It's a higher dose of FSH during her stimulation. Despite this high dose, only 1 to 3 oocytes were retrieved two times. So she will be called poor ovarian response even if her age is not advanced and an ORT is normal. What is ORT? Ovarian reserve test is normal. What ovarian reserve test are? AMH and AFC. If these are normal. So, what is maximum ovarian stimulation? When we'll call maximum ovarian stimulation means using the highest safe and effective doses of fertility drug to stimulate ovary to their full potential. To their full potential. This is called maximum ovarian stimulation. So, what are these other risk factors? This criteria do not explain these other risk factors. Okay, so I read what article in Journal of Ovarian Research in which the other risk factor were defined. The suggested other risk factor include, first is other risk factor. First is short menstrual cycle. Women with short menstrual cycle are linked to poorer IVF outcome and reduced ovarian reserve. This means their chances of successful fertilization is lower. Okay. Second is single ovary. Single ovary. If a woman has only one ovary, either due to surgery or other reason, it is associated with the earlier menopause. Earlier menopause and lower ovarian reserves. Okay, this can make fertility treatment more challenging. Third is ovarian cystectomy. See, surgery to remove ovarian cyst, especially for conditions like endometrioma, can damage ovarian reserve and reduce live birth rate in ART treatment. Fourth risk factor is smoking, chronic smoking. Smoking has been shown to reduce ovarian reserve and impair ART outcome. Fifth is, this is smoking. Fifth is unexplained infertility. Sometimes the cause of infertility is unknown. In such cases, it is often linked to early menopause. This sometimes it is unknown. So it is most often linked to early menopause and reduced ovarian reserve, suggesting an underlying problem with ovarian function and diminished ovarian reserve. Sixth is previous chemotherapy or radiotherapy. Women who have undergo cancer treatment, like who have undergone chemotherapy and radiotherapy, often experience early menopause and significant reduction in ovarian reserve. Seventh is radiotherapy. Seventh is family history. Family history of premature menopause. A strong genetic link has been observed. If a woman mother's experience premature menopause, the daughter is at high risk of lower ovarian reserve and early menopause. Eighth is X chromosome derangement. Genetic abnormality in X chromosome are commonly linked to primary ovarian insufficiency and early menopause. If there is some X-linked disease, this is seventh, eighth. If there is some X-linked chromosomal derangement, there will be primary ovarian insufficiency and early menopause. This can severely affect fertility. Ninth is fragile X mental retardation 1. Fragile X mental retardation 1. Premutation. Women with this pre-mutation often has diminished ovarian reserve and are likely to experience early menopause. This condition can reduce the chances of successful ART treatment. Now we'll talk about the limitation of Bologna criteria. This is also discussed in this article. Okay, what are the limitation of the Bologna criteria? Heterogeneity of population. First is heterogeneity of population. See, Bologna criteria, the group women with different conditions under the same category poor responder. It kept all the women for very different conditions under the same category of poor responder. This creates confusion in both research and treatment. Example, imagine two women, woman A and woman B. Now this woman A is 42-year-old and has low ovarian reserve because of age. And women B, this is 30-year-old and she has some genetic issue like fragile X pre-mutation. Okay, genetic issue. So even though their conditions are completely different, the Bologna criteria will put them in the same category. Now there is a problem because the treatment that works for woman A is different for the treatment that works for woman B. These two different. This make it difficult for doctor to generalize result or prescribe effective treatment. Okay. So heterogeneity, this was the limitation. Second is cutoff value. See, as we have seen, the threshold for test AMH and AFC are not standardized, which means different clinic might use different cutoff to diagnose poor responders. See, in this, some may use 5 as a criteria for being a poor responder. Some may use 7 AFC as a criteria for being poor ovarian responder. Similarly, for AMH also, some may use 0.5 and some may use 1.1 nanogram per ml as a criteria for being poor responders. So different clinic may use different values. So this inconsistency can lead to different diagnosis and treatment for the same patient, which is unfair. Okay. Third is risk factor. See, apart from the age, other risk factor for poor ovarian reserves are not clearly defined in the criteria. This reduces the reproducibility of the diagnosis. Example, let's say woman had a chemotherapy in the past, okay, which is major risk factor for poor ovarian response. However, because of the criteria does not clearly include this as a risk factor, some doctor might miss it and the woman might not receive the right diagnosis or treatment. Okay. See, the risk factor I told you was after the criteria which was published in this journal, but the criteria does not talk about the other risk factor. That's why it is the limitation. This journal talked about the risk factor. Okay. Now, oocyte quantity vs quality. Fourth point is oocyte quantity vs quality. The Bologna criteria focuses heavily on number of oocyte or number of oocyte retrieved, but means it heavily focused on the quantity, but do not consider their quality. Ignore the quality, which is more important for, it is also very important for the pregnancy. Okay, example is a woman undergoing IVF retrieved 8 eggs, suppose 8 eggs. Okay, this sounds good, right? It sounds good. But after testing, doctor finds out that the eggs are of poor quality and cannot form a healthy embryo. So this shows that quantity alone cannot guarantee the success. The focus needs to shift on the quality as well. Okay. Now, fifth point. Fifth point is overdiagnosis. Overdiagnosis. See, if patient is over 40-year-old and it has a risk factor for POR like abnormal ORT. ORT is ovarian reserve testing. Either AFC is below 5 to 7 or AMH is below 0.5 to 1.1 nanogram per ml. So if these two are present, so even without undergoing a stimulation, we'll say it as a poor ovarian responders. So they are often directly recommended ART without even exploring ART like IVF or ICSI, without even exploring other natural conception or mild stimulation. This is based on the assumption that their success rate is already low. So proceeding with ART quickly is seen as a better option. So this is kind of an over diagnosis. Okay. Now, last point is lack of large scale validation. This Bologna criteria has not been validated through large scale studies, making it difficult to confirm if they work universally in clinical setting. So why this is important? These limitations, to know these limitations are important because these will show us where improvement are needed, and if we can address the gap, like adding genetic factor, focusing on egg quality and conducting large studies, the criteria can become more reliable and help doctor to get better and more individualized, more personal treatment to the woman undergoing ART can be given. Thank you.